for that segue, and Webb, thank you as well. That is a nice transition into what we're going to talk about today, which is building your early career reputation offline, or perhaps social media marketing, but not online social marketing. How do you build your career? And really, as I was thinking about this, this first slide that, well, I guess my second slide, the slide that I'm about to show, hopefully, this sums up the whole thing. So, do the right thing. It sounds easy. It's not necessarily always clear or easy, but if you go into a market and you'd like to be dedicated to that market, you plan to stay in that market, the best thing that you can do is always play the long game and do the right thing. I know that a lot of you out there are trainees or just starting in your practice, and what you want to do is spine surgery because you've spent the last 15, 20 years of your life, getting to this point, and then you get out and you just want to do some spine surgery, not because necessarily you want to make a bunch of money or whatever else. You're just excited to do the thing that you've been waiting to do. And some of the advice that I got was, you need to be super, super conservative, even more conservative than anyone else. And that's for a number of reasons. One, everyone is watching you. So if you have partners or if you have competitors in the marketplace, the OR staff, the clinic staff, everyone is watching you because they want to know who this new surgeon is, and are they good? Are they not? Are they a good person? Are they not a good person? And so, everyone's watching. It's like the newspaper test. Are you okay? If this was on the front page of a newspaper, are you okay showing every single case that you do and every case you indicate at a major conference in front of everyone? And if you are, I think that's a good sign. You're on the right track. So really always doing the right thing, treating every patient like your family member. It's just not like sexy advice, but it really works. And what you'll find is you're gonna have this payoff in the long run because people are going to respect you. So yes, you may be slow up front. And as John said, I'm in Dallas, Texas area. There's something like 300 spine surgeons here. And I did almost no clinical work for probably 6 months. And the rest of this talk is I'm going to tell you what I did for that period of time. And fortunately, my practice has really benefited from that, and it's still continuing to grow. But just do the right thing. So what does that mean? So one, be nice. Don't be a jerk. Don't be a typical surgeon, right? Like, treat people with respect. Learn people's names. Be available. Can you see my patient? Yeah, I'll see your patient today. I will move things around. I will add them onto my clinic. And certainly don't get a reputation of being a cutter, because everyone knows who those people are. The primary care people know, doctors know who those people are, and that will rapidly come around to burn you. So, you're just starting out. You've got a bit of an inferiority complex because there's all these, gray hairs around you who have very established, nice practices. And like, you don't want to let on to your patients like, yeah, this is like the 4th case that I've done as a solo surgeon. And so you've got a little bit of that going on, but you have to focus on what is your competitive advantage. And you have to optimize that. And to me, as an early surgeon, and this is what I tell my fellows as well, is what you have that other surgeons don't is time. So, as an established, busy surgeon, it's a bit of a rat race in some respects, and you're trying to get through your day. You've got OR to get to. You're trying to get through a certain number of patients in the day. You've got a busy day. But when you only have 3 patients in a day, you can spend an hour with that patient, speaking with that patient, explaining everything to that patient, talking to them about the surgery, whether or not they're operative or not. Because every patient that you see is a potential old-fashioned marketing opportunity. Even if they have back pain that's non-surgical, it gives you the opportunity to make a connection. They have a wife or a kid or a neighbor, and those things will come back to help you build the practice. So you do have an advantage, and you should really exploit that. So into some like nitty gritty and actual tangible things. How do you identify potential referral sources? And that's what you want. You want to build a referral network of people that can feed your practice. Here's the way I think about things. It's kind of like patient arbitrage. It's maybe cynical, but as long as you're aligning yourself with good people at every step of this process, then it's a good thing for the patient. And so the way that I think of it is there's a flow or a flow chart of patients. They start at the primary care doctor, and then they get referred to the spine surgeon. Now, I get a lot of patients referred to me by primary care doctors. Very few of those patients end up actually being surgical because it's not the primary care doctor's training or really their job to do a complex workup of a spine patient and decide whether or not they're surgical or manage them or work them up. So they've got a back problem or a neck problem, they get sent to you. Then you make an assessment. And more than likely or not, you send those patients to some specialist, whether actually they have hip pain and it's not their back pain, so you're sending it to an orthopedist. Or maybe you send them for an injection or to a pain management doctor. And so you're then kind of triaging these patients to all these different specialists who are perhaps in a better position to identify who is kind of a prime operative candidate from a spine perspective. And then they are then sending you back kind of worked up, higher yield patients. And so each part of this is very important. So you can't look at it and say, oh, all the patients I get from primary care doctors, none of them are surgical. And so I'm not going to waste my time making those connections, because you really need those primary care referrals to feed the specialists who then in turn send you more likely operative cases. And the key is to, again, align with everybody along this who you would send your own family member to. And so then, patients are getting good care. Where do you find these doctors? Well, one thing that I did very early on was just cold calling. And you get out of training and you think, oh my gosh, I'm a hotshot spine surgeon. I'm going to do, spine surgery and, have a full office. And hopefully that's what you have, but it's not what I had early on. And so I would just drive to a given medical center. We have a ton of them in the Dallas area. And I would park my car and I'd go to medical office building 1 or medical office building A or whatever it is. And I would take the elevator to the top, and then I would walk the stairs all the way down every single floor. I had my suit on, I had my business cards in my pocket, and I would knock on every single door and say, hi, I'm Peter Derman. I'm a new spine surgeon in town. Is there a doctor, nurse practitioner, PA, anyone who will speak to me? And that's how you get in the door. And then, I'd go through every single building in a complex. And the next time I'd go to a different complex. And when I got to all of them, I'd start at the first one over again. And you know what? A lot of the times you're going to get turned away. But I'll tell you, if you're persistent, and what the heck else are you going to do? You got nothing to do. You're going to find some people that end up being really good contacts for you. So what do you do when you get in the door and you've actually gotten in front of a doctor who might be a potential referral source? This is kind of my go-to thing. Was one, I would introduce myself. Before COVID, you could shake their hand, which was very nice. You could see their face. It's a new challenge these days. But you've got to have your elevator pitch. I went to business school also, and that's big in the business world, elevator pitch. It's like 60 or 90 seconds of who you are and what value you add to that doctor. And you might think, oh, I do this really cool surgery and blah, blah, blah. You got to put yourself in their shoes. What do they want? And different kinds of doctors are going to want different things. And so you got to think about what differentiates you and how does that feed into what they are looking for in a spine partner. So you talk to them, you give them your spiel, and then I always try to I always give them my cell phone number, and I always try to get their cell phone number. And we'll come back to why this is, but it comes down to communication and maintaining the relationship. So often what I'll say is, hi, hey, can I send you my contact information? And then you get their cell phone number in the process of doing that. obviously you don't abuse people's phone numbers, but it's nice to be able to have that connection. And then I always, as a rule, would write a handwritten thank you note. And maybe this is old fashioned, but my mom, like, ingrained this in me, that there's value in writing a handwritten note. So I would always, as soon as I, got back to my car, I'd write a handwritten thank you note that had something specific about the conversation that we had. So they know that it's not some BS form letter that I write to every single person. And I think, it's pretty easy to figure out when that's the case. And then you can either mail that to them. At TBI, we're very fortunate. We have a pretty robust marketing department. And so what I would do is I would give those handwritten thank you notes to the marketing department, and then it would give them an excuse to go back and call on those offices again. So, hey, I have this letter from Dr. Derman, and that would kind of get them in again, and it kind of reinforces the pitch that you already gave to that doctor. The other thing is, if you have time, you can drop that off yourself and kind of ingratiate yourself to the office staff. It can also be important in some cases to know who controls the referrals. So in some practices, the doctor does it. He just says, okay, send to orthopedics or send to spine. And it's good to try to find out, is it their office manager that makes that decision? Is it the MA? And then to make sure you're having a relationship with that person as well. What else can you do other than random cold calls and the occasional meeting that you can set up? Lectures at conferences and seminars can be a good way to get a lot of bang for your buck. And so these can target patients. They can be patient focused, or they could be potential referral source focused. This is one that one of the hospitals that I like to work at put on for me and a hip replacement doctor. And we give a talk together. Is it the back or is it the hip? And this is one that we gave to a local group of potential patients, community members. And I can't tell you how many people that I've seen in the office who came to one of these events, saw me, and then either personally came or sent their neighbor or their husband or something else. So this is a good way to really get your name out to a large group of people in a relatively condensed amount of time. I also like to speak. We're actually giving the same talk tomorrow at a large physical therapy group in Texas. Physical therapists can refer directly. So physical therapists are a good source of referrals. So we're going to give that tomorrow. I've spoken to the Chiropractic Association on multiple occasions. That's a good group of potential referral sources. And then the other thing is internally, at the spine societies and things like that, that's not getting you direct patient referrals, but it is good networking and building your brand. And so I think that doing research and being academic is helpful in that respect as well. It helps. This is not a very small patient. This is my son, by the way. I'm not above bringing my kid to these talks because he's really cute, and it helps be more memorable. He's much cuter than me. And then, you've made that connection, and you walk out the door. How do you maintain the relationship? And it's only going to be 1 in 20 or something that ends up being a consistent referral source, but you want to make sure that you maximize that number and then retain those referral sources. And for me, that's all about primarily communication. And so, every time, well, one, always write good notes. I write pretty extensive notes. I think it's really important. It helps me because I can remember what I was thinking the last time. But we send all of our notes, as a rule at Texas Back, to all of the referral sources, who referred us the patient, and then all the primary care doctors. And I've had multiple doctors comment to me that they really value the notes that I write because I spend time to actually give, a HPI, a real exam, a real assessment, and a real plan, and spell that out. And so write good notes and send them to your referral sources and to the primary care doctors, and then picking up the phone. And so for me now, still, and I have a reasonably busy practice, I spend about half an hour to an hour at the end of every clinic. Whether or not it's the first time I've seen that patient or the 5th time I see that patient, I reach out and I say, hey, I saw Miss Smith back. This is what's happening. I think she's doing well. Hopefully we can avoid surgery altogether. Thank you so much for involving me in her care. And one, it's just good medicine. And two, it's just a reminder. Hey, I'm here. I'm a good surgeon, I'm a good person, I'm looking out for your patients, and the next time they have a patient to send, you're kind of top of mind for them. Early on, when I had very little to do, I would not only reach out to the referring doctor and any doctor I then referred that patient to, but I would call every primary care doctor. So say they were sent to me by a pain doctor, I know from the chart who their primary is. I would also call their primary care doctor. And I would give that primary care doctor my elevator pitch. And then I'd say, this is my cell phone. Please never hesitate to reach out to me. And so just really trying to expand your network, and communication is a big part of this. And then, so what primary doctors tend to want is that communication, to know that you spent time with the patient, that patient's not going to come back to them and complain that you were a jerk to them, and that you've closed the loop. Specialists oftentimes will want referrals in return, and you really need to make sure that you're reciprocating. And I said this before, you got to make sure you're working with people that you respect, because every patient you should treat like your own family member, and you should never, ever, ever send a patient to a doctor that you wouldn't send your own family to. So it's a matter of really figuring out who's who. But once you find your group, your team, whether that's a hip and knee surgeon or a hand surgeon or a pain doctor, it's important that you do reciprocate, because they're trying to run a business also, and they want a real partner. And so if you're not doing a good job of periodically sending them patients, this relationship is ultimately going to dry up. Oh, and I put Doogie Howser on here. I wanted to remind myself here. Who's an ideal target for you as far as potential referral sources is? I would argue that it's somebody that's in your peer group as far as how far you are outside of training. So most of us are relatively young and early in phases of our career. And those are really the ideal people, in my opinion, to strike up a conversation with, because they're not so set in their ways as far as their existing referral sources. It's going to take a lot of effort for you to disrupt a long-term relationship. And I don't say disrupt in a negative way, but it's going to be hard for you to break in there, because these people have been working with their network for a long time. But if you can find somebody who is like you, a year, 2 years out of practice, somebody you really respect, and somebody that you can grow each other's practices together, I think that is going to be the highest yield for you. And then the snowball effect. So just keep your head down, keep doing good work and being a good person, doing the right thing, being available. I tell my referral sources, you can call me anytime. If you have a patient that needs to be seen, just call me, let me know the information. If I'm in the clinic, I will add that patient on. I will do whatever it takes to see your patient. Like, if you continue to do this and you reach out and you communicate and you reciprocate and you get out there and do things. For instance, I had a cancellation today because a patient didn't get cardiac clearance. And so I went and I had 3 meetings with 2 existing and 1 potential new referral source. So, every opportunity you get, you should do this. Just like Webb said, he stopped by an urgent care. I had a layover at the airport at DFW one time, or I had a delayed flight, and I went to the urgent care in DFW. So if anyone's in DFW, don't go to that urgent care. That's already mine. But anyway, things will snowball with time. And what ultimately will happen, and people talk about 5 to 7 years of building your practice. And what that ultimately means is, by that time, you have seen and touched enough patients that there's a self-fulfilling referral source. And perhaps, and we can ask some of the more established doctors on the panel, perhaps you become less dependent on these referral sources because things have snowballed and kind of take on a life of their own. But I would still encourage you to continue to communicate and continue to do the right thing. So those are my 2 cents on building a practice in the real world outside of social media. I do also use social media, as you can see here, although I'm no Antonio Webb. But certainly if you have any questions for me, please don't hesitate to reach out. My information is here.
Thank you very much, Dr. Derman. That's awesome. And I encourage anyone that hasn't been to his pages, if you want to see someone talk about spine care while doing a handstand, that would be worth your time. So we have a bunch of questions, so I'm going to start with some, and Sandy will help me ask some of these too. So Dr. Webb, a question for you that I think a lot of us think about with social media is kind of the privacy issues around whether you're talking about a patient's face, that maybe wants to say, like in Derman's case, I'm doing great right after surgery and I feel awesome, or even just x-rays and images that don't necessarily directly implicate, that patient, or however you want to phrase that. What are the considerations you have for that? What do you have in place? What are kind of the recommendations, best practices, in your opinion, in kind of this evolving field?
Yeah, that's a great question. I think bottom line, you have to be very careful. Some organizations, hospitals, they have policies in place about filming or taking pictures in the operating room. So you have to check with your local hospital or your group or your practice and see what their policies are. But in fellowship at Texas Back, there are consent forms that patients can sign that gives us consent to use, in terms of their images or whether that's a video, but that language in that consent form has to be very specific and particular to what you're doing. And even if you blurt out the patient's name, date of birth, there still can be some identifying things in that x-ray, whether it's a certain implant or how the pedicle screw was positioned. You just have to be very careful and make sure that the patient understands what you're doing with that particular x-ray or image and how you're going to use it. But getting written consent from the patient, I think, is probably most important.
I would also argue don't get written consent for them immediately before or after surgery, especially if they have Versed or something in their system, because that's clearly a questionable practice.
Great points. Thanks, gentlemen. And then a question from the group for Dr. Derman this time. Can you touch on how you deal with the increased number of patients showing up to your office with a diagnosis in hand from the internet?
Google Scholar.
Yes.
I actually like patients who are engaged in their care. And so while their diagnosis is not always correct, and I'm guilty of misdiagnosing myself and my family of all kinds of non-spine related things, it shows to me that they are working hard to find answers. And so I try to use that as a educational piece and a pivot point. Yes, you have X, Y, and Z. If you put that into the internet, I can see why it would say that you have this. Here's why you don't, and here's what you do have. And so, I would rather have the patient who's educated on what's going on than the person that's not engaged in their care. Because if you can re-educate them or direct them in the right way, they can really be a good partner with you in the care that they receive.
Makes total sense.
Next question for you, Dr. Webb, is kind of the issue of with social media. One of the things I think we saw with celebrities, a few years back on things like Instagram is, the difference between, hey, look at me outside and I just happen to be wearing Nikes versus like Nike's paying me for this ad, and the kind of the hashtag ad or however they're going to denote that that's what they're doing. As a surgeon, we're putting in implants from specific companies and might have a financial interest in things that if we were giving a talk like this, we would talk about. But if we're doing endoscopic surgery with Joymax and we don't necessarily say that I'm consulting for Joymax, how do you think of that? How do you frame that? Do you ever feel the need that this is conflicting enough? I need to mention that. What are your thoughts on that?
Yeah, certainly. That's always a question anytime that you put out anything on social media. Just like when, I film a video, maybe going to a cadaver course that's maybe sponsored by some company, whether I need to mention that. But that's certainly something that, is not done enough in terms of just revealing any potential conflicts that, you may have with any type of social media posts. But it's just something to think about. And if you feel like there's a conflict of interest, you should certainly mention that.
I forgot to mention I'm sponsored by Nike.
Thanks for chiming in there. Good to know. Perfect. All right, one question that was brought up by our group of attendees that I'm personally interested in is delegating. And especially one of the things I was wondering is about social media. So as someone in academics, I think of research and research productivity and delegating things to clinical research coordinators or research interns. And then I think of social media and the amount of time that it takes to develop that kind of presence. So for either of our speakers tonight, do you use any assistance or do you delegate any of your social media presence? I know Dr. Derman, you spoke to Texas Back's, I guess, advertising division.
Yeah, we do have a very good marketing division. They tend to market the practice as a whole. So I have my own social media platform pages, and I manage those myself. We'll hear from Dr. Webb and see what he thinks. Clearly, my work is not nearly on the scale that he is, but I do manage it myself. And part of that is I think you can often tell when people's social media pages are not managed by them. You see a lot of very generic stuff like a stock photo of someone exercising and it says like, I feel great after my hip replacement. And you're like, come on, like I know that you didn't make that. You paid some marketing firm and that's pretty bad. So I try to at least make it personal and add a personal touch about what I'm talking about and what I'm posting and make sure that there's like real content there. Webb, what are your thoughts?
Yeah, I certainly agree. You have to make it personal. For me, when I first started, I've been on social media maybe for 5 to 6 years. It's not to the scale where I'm doing now. Now I do have a team of people that help me in terms of editing, shooting videos, graphic design, and in terms of things that need help online. So, but first starting off, you don't really need all of that. It's just put up a video, unedited it. It doesn't have to be really nothing spectacular that can get information out that you're trying to get to your patients. And I shot most of my videos on my phone first starting off, and that really, looking back, I'm like, wow, that was a really horrible video. But you don't really need, kind of a whole team of people like I have now. And it does certainly take some time, but on the flip side, I have a passion for videography. I can sit and edit a video for 6-7 hours. That's what I love to do. So if you're not into that, then that may be kind of a downside of doing all this. But there's websites, there's companies that can help you put out information. But you certainly do have to make it personal, though.
And then the next thing I wanted to touch on for Dr. Derman more is, when I was going to meet with some docs, like you were talking about the handshake philosophy, and I'm introducing myself, I'm doing my quick pitch, I felt like I ran into a lot of primary care docs because I'm in an ortho group and would treat some of that where they would say, well, do you take this? Do you take kids fractures? Do you take Medicaid? Do you take, and like technically insurance wise, yeah, we took everything and sure, like I'll do this or I'll do that. I want to please them and say like, yeah, I'll do this. I want your referrals and I'll take a couple kid fractures to do this other thing. But, in your case, especially with the endoscopics, which we didn't really get super deep into today, but you've developed this really interesting niche where even other spine surgeons in a spine group can generate some internal referrals for you. How do you balance on the marketing side of things, the difference between doing the practice you want to do versus being broad enough that you can get interest?
Very good question. Very good question. I think you start broad. And you have to think about how comfortable you are treating different things. So I came to spine through ortho. I never did general ortho. I joined Texas Back Institute. It's easy for me. All we do is spines, right? So like nobody's sending a peds, both bone forearm fracture. Right. But I think you should be as broad as you're comfortable doing. I'm not sure that I ever would have wanted to do general ortho. And I think in a major metropolitan area, you're justified in saying, listen, I was trained in these things, but what you want is a specialist. You want the person that should be the one taking care of this problem. Yes, I can nail this hip, but should I be the one doing it? However, I'm a spine surgeon and I will take care of all of your spine needs. And John, I still say that. There's certain things that I don't like to take care of, but I want to be that person's go-to person, because to your point, that primary care doctor doesn't want to say like, oh, Burleson doesn't do kyphos, he doesn't do deformity, but he does do tumor, and he doesn't take this insurance. No, if you got a spine problem, send them to Derman, and then you can always send them to one of your partners after that, right? But you should try to make yourself the nexus, the go-to person. And I think that referral sources respect the fact that if they send you a patient and you don't feel like you're the perfect person, that you selflessly then sent them to the perfect person, because they don't necessarily know who the right person is.
That's a great point. I think you should include kind of the age group. I got that question today. Hey, do you take peds, or do you do this procedure? You have to have that in that elevator pitch. That's so important. And just like, when I was talking to Peter in fellowship, he's kind of anti doing ortho. I do a lot of general ortho, but I did a lot in my residency and feel really comfortable. But I got a text message today from a pain physician say, hey, do you do shoulders? I'm not doing any shoulder scopes or kind of rotator cuff repairs, but I told that physician, hey, I'll connect you with somebody that I trust and I think will be really good. So even though I really wanted to see that patient and hopefully build a relationship and get my name out there, I just told him, hey, I'll connect you with another person, and I think it's probably best to take care of that patient. And
I got to ask, I know I just asked the last question and I wanted to alternate with Sandy, but I'm stealing this because I got to know the answer to this. Webb, when we did the paper you presented there real briefly, we looked at all these social media websites that people could have, right? And are they actually using them? One of the ones we didn't look at, and I want to get your hot take on this, is what about the really new social media things like TikTok, for instance, where you can get 20,000 followers in a week if you're super dedicated to catch fire. But what about the problem of demographics? That TikTok might be all 19-year-olds and 20-year-olds, and the difference between the Facebook crowd versus Instagram versus Twitter. Like, do you use that to play into your time in terms of thinking of cost to acquire patients? Like, does it get that granular, or do you just say, let's just build the mass and then we'll put the media out there and see what happens?
I just stick with what I'm comfortable with, and I can't dance, so that kind of eliminates me from starting a TikTok or a Snapchat. But yeah, you have to think about the demographics. Kind of the Instagram is kind of the younger population of people that can potentially be patients. YouTube is kind of a broad spectrum. There's millions of people on YouTube every day, so it's a broad spectrum. But I haven't really got into TikTok. I don't think that's kind of my thing. I'll leave that to the younger guys and gals who can dance and do all those things. I certainly can't do that.
Very cool answer.
Awesome. Well, thank you, everyone. Obviously, you can subscribe and see any of these future talks that we have. We try and bring something new and interesting every month. We're always trying to look for new speakers, too, that are interested, and some topics that you guys are interested in. The CME credit's a big part of this. There's the information. You just text that number within the next 2 hours, and you can get credit. And then if you subscribe, you get on our mailing list so that you know when we have these. If you can't make